It's my pleasure to introduce our next speaker, David Gendelberg. Pull up here to talk. And Dr. Gendelberg will be speaking about the timing of spine surgery in the setting of polytrauma.
Thank you very much. Thank you, everyone, for being here. Thank you for inviting me. So there's a high incidence of spine injuries and blunt trauma. They occur in 6 to 10% of major traumas, and up to 50% of them are associated with other major system injuries. The most common location is the thoracolumbar spine, with the junction being most vulnerable due to the transition zone. And you often have multiple levels involved, as you can see in the MRI up here. And so why does the spine matter in polytrauma? Well, obviously the spine controls the neural elements. It transmits the weight of the body and helps us stabilize ourselves. And in polytrauma, there's high neurologic morbidity, and you have associated neurologic deficits in up to 25% of polytrauma patients. Spine injuries delay and impair systemic recovery. It limits mobility. Patients who are under spinal precautions in the ICU, in collars and whatnot, with all their precautions, are at risk for pneumonia, and also it prolongs the ICU stay. However, when you treat the spine in a timely manner, the patient is able to mobilize earlier. It's better for pain control, better for care for the patient, and it gets them out of the ICU faster. And so, like everything in trauma, it starts with the ABCs, and part of the ATLS is that all trauma patients should be presumed to have an unstable cervical spine injury till all aspects of the cervical spine have been adequately studied and an injury excluded. And this is very important because if you don't identify the injury, you could potentially make it worse and cause real harm. I've seen a few cases of patients coming in to the hospital and due to missed injuries having further catastrophic injuries. And so, again, a thorough evaluation of the patient, including neurologic exam, seeing different patterns to see if you have a spinal cord injury pattern. And our residents know this quite well. Always do a rectal exam. I can't tell you the number of times that has been the identifying factor of spinal injury in a patient. And so generally speaking, CT is the first line. It's obtained in all traumas nowadays and is standard of care. The MRI clarifies whether there's neurologic involvement and assists in defining occult instability. However, it's often difficult to get it in a timely manner. And so sometimes, especially with our ligamentous injuries, we have a delay in diagnosis. And another important image modality is the upright X-ray, if the patient is able to get them to assess for stability. And so who doesn't need imaging, though? So according to the Nexus criteria, the patient has to have a GCS of 15, no evidence of intoxication, absence of tenderness, absence of deficits. But the key is no distracting pain elsewhere. Therefore, these don't apply. And so back to our spinal indications, every polytrauma needs to get imaging. And so what is instability? Here I have the famous quote by White and Punjabi. And basically, it's the loss of the spine under physiologic loads to maintain its patterns of displacement. So there's no initial or additional neurologic deficits, no major deformity, and no incapacitating pain. And so in surgery, we're able to decompress what is compressed, stabilize what is unstable, and the goals are also to prevent late deformity. And so to this, we have classification systems, and we like to argue about which ones we like to use. You've got the TLIX, you've got the SLIX, you've got the AO spine classifications, and so on. These are complementary. They're not meant to compete with each other, and each one gives us a piece of information that putting together helps us manage our care and to determine the stability and acuity of the injury. And so generally speaking, the mantra is life over limb. You need to prioritize vital physiology, and surgical intervention should not endanger the patient's life. It's a dynamic decision. Oftentimes, you could resuscitate the patient while also managing the spine. That is very center specific, and a lot of it depends on the capabilities of the anesthesia team and what they are comfortable with doing. We know that early fixation improves outcomes. Generally speaking, there's a 24-hour target for spinal cord injury, and the lactate maps and the patient's coagulopathy status needs to be controlled. In damage control orthopedics, we talk about the first hit being the initial trauma, and this leads to the initiation of an immune inflammatory response. But then you also have the second hit, and that affects, that influences early interventions. Interventions in the early phase of care may drive the patient over an edge and lead to organ dysfunction, morbidity, and mortality. And so, first and foremost, the patient needs to be resuscitated. You want to avoid the lethal triad of hypothermia, coagulopathy, and acidosis. After the patient is resuscitated, then you could progress to take them to the OR. Again, the patient's safety is of utmost importance. And generally, we talk about a lactate of under 4, pH of above 7.24, base access bit better than 5.5, as well as decrease in pressure requirements. And so, kind of to exemplify these points, I have this 15-year-old female who jumped from a window, had this L3 burst fracture with numbness and a visceral injury, status post XLAP, and she also had a pneumothorax. And so initially, I just did a posterior stabilization and decompression. There was discussion about whether to do a corpectomy that day or in a staged fashion, but we felt with everything going on, less was more. We achieved the initial stabilization, and so we just came back 3 days later and did the corpectomy once she was more stable and resuscitated. Now, this talk is all about timing. So there are different levels of urgency depending on the type of injury. Generally speaking, neurologic deficits with ongoing compression, cord injuries, and bladder involvement are the most emergent. Then I would kind of call very urgent your high risk mechanical instability. You know, the patient may be intact, but you know, all it takes is one bad transfer, one bad log roll or something, and it may displace and cause catastrophic injury. When you have radicular deficits, generally speaking, motor deficits, in my mind, take priority over sensory deficits, which is why the sensory deficits are a bit lower. And then you have the low-risk mechanical instabilities where you have a low likelihood of neurologic injury and you're really treating it to prevent future deformity. Now, we always talk about timing of cord injuries, and obviously we all know that cord injuries could be catastrophic. Time equals cord. MAP goals may also conflict with other injuries in the setting of polytrauma, and so that's where the role of perfusion pressure monitoring may be of use, as well as temporization. The STASCIS study shows that intervention before 24 hours led to significant improvement in neurological outcomes and supported early surgery. At our institution, we did a further investigation examining ultra early surgery, and we found that intervention in under 12 hours provided even more benefits. There is some discussion about this data, but overall, what it comes down to in my mind is if this were any one of you or one of my family members or myself, I would want to be cared as soon as possible. And so when I have a patient with a spinal cord injury, I get them to the OR as soon as possible. So with cervical spine injuries, we prioritize spinal cord injuries. Early fixation also stabilizes the airway, makes it easier to care for the patient. When choosing your approaches, you need to look at the injury pattern as well as what are the concurrent injuries. If the patient cannot be in the prone position, and I just reduced jump facets and have the option between a posterior approach or an ACDF, that may make me lean towards an ACDF as opposed to posterior fixation. Thoracolumbar injuries, neurodeficits require early stabilization. We have the discussion of cord level injuries versus radicular level injuries. And when you have neurointact unstable fractures, you need to evaluate the risk of acute displacement as well as the consequences of the acute displacement. But also early fixation of thoracolumbar injuries accommodates patient care with mobilization, upright positioning, and also with ambulation, you have less risk of a DVT. So generally speaking, you want to fix the patient before 72 hours. Studies have found that those patients have improved ventilator days, ICU days, morbidity and mortality. However, this did not translate to the lumbar spine in these studies over here. Another prospective study found that there was actually higher mortality in an early group as opposed to the late group. However, all these cases were done open. They found that patients that had hemoglobin lower than 10 did worse, and those with a thoracic drain did worse. And so in my mind, brings us back to resuscitation. You want to try to treat these injuries within 72 hours, provided the patient is stable and resuscitated. So when the spine competes for priorities. So vascular injuries with hemorrhage to control leading to limb perfusion, those are of high priority as well. Head injuries with elevated ICPs, prone positioning may be problematic with those, and so those patients need close monitoring, as well as some long bone fractures, which may influence the hemodynamics. Pelvic injuries, as well as open fractures, could compete with spine injuries. And so sometimes you need to employ what I call damage control spine surgery. And so from a non-operative approach, you could do closed reduction, traction, put the patient on spine precautions. From an operative standpoint, you could use MIS techniques, do a staged approach, short segments, or decompression alone, and then come back another day and put in the hardware. Here I had a 54-year-old male who was very lucky. He had a history of a T7 Asia A injury in his 30s, but then he fell out of bed and sustained these C6, C7 jump facets and was a C6 Asia A. And so I closed reduced the patient, and here you could see on post-reduction MRI that there is no pressure on the canal. And so by doing the closed reduction, I actually took this patient from being an emergent case and made him an urgent case. And we were able to do him 1 or 2 days. We were able to do him the following day after more stabilization. And so intraoperative challenges. The surgical load affects the patient's physiology. It's important to communicate with their anesthesiologist and know the resuscitation status of the patient. I call this active resuscitation. The prone positioning could be risky, especially with patients with lung injuries, flail chests. If the patient has an open abdomen, it's controversial whether to place them prone, as well as with an unstable pelvis. And this is where communication among all the different teams is critical. And so it comes down to shared decision making. You need to have a centralized leadership, which is usually the trauma surgeons, that's able to kind of guide all the pieces together and make sure that everyone's in communication to avoid siloed decision making. Pre-op huddles are important to reduce complications, and I'm always talking with my anesthesiologist during the case to ensure that the patient is doing well. You want to put together protocols to reduce variation. There's no need to reinvent the wheel, especially not during an emergency. Checklists, as well as performance metrics. Here I have a 24-year-old female who had a flail chest and a thoracic injury. She did prone positioning. That isn't ideal with the full chest. So you could take different measures, like using an anterior TLSO to protect the chest and spread the load so that you're not putting pressure on the chest. So there are also a lot of different techniques that you could do to help mitigate secondary injuries. And so generally speaking, the first priority in these patients is stabilize the physiology. The second priority, I would say, are the cord injuries. The standard of care is 24 hours. There's no real consensus with less than that, but earlier is better. Then I would say non-cord neurological deficits. And then obviously a high priority, the unstable injuries without deficits, but ideally within 72 hours if the physiology allows it. And so I'm bringing here my urgency graph for people to kind of take a look again. And take-home points are triage and polytrauma is essential. Intervention prior to resuscitation increases morbidity. You need to understand the spine injury characteristics to know how urgent, emergent, or less urgent the injury is. Neurological deficits are high priority. You need to employ damage control spine when needed. And we're all part of a team and everyone should be communicating with each other. Thank you. Yeah.
In the high velocity injuries with head injuries and the patient's comatose for 2 or 3 months, and they all have MRIs, and the trauma surgeons want you to clear the spine. They've already had an MRI and the readings are always the same, edema or ligamentous injury. How do you clear those cervical spine injuries that are non-responsive? How do you use a collar? Do you use a collar? How long? Is there any role for flexion extension x-rays?
So is the patient awake or not?
Yeah, the patients that have head injuries that are not awake.
Okay. So in general, with the negative CT and the negative MRI, I do feel comfortable clearing the spine in a patient who is unexaminable. However, if you do see edema and signs of injury in the cervical spine, I personally keep the collar on. I would not do flexion extension images with a patient who is unable to respond. Now, then it becomes a question of, that comes up is often if they want to trach the patient or for care, they want the collar off. And then it's a per patient discussion, kind of evaluating the actual, like what the MRI shows, how severe it is, and each case is different.
And how long do you leave the collar on if you see edema?
I mean, generally speaking, I'll leave them on for 6 to 10 weeks. But again, it depends on the injury. Maybe I'll do a repeat MRI, see if things have calmed down a bit.
Great talk. And one question is, what's your opinion on the CSF drainage in the setting of cord injury? Do you believe it's helpful, or is it, sometimes with multi-trauma, maybe a little hard to manage?
It can be very hard to manage. I mean, I think there is some promising literature, but we also know that we need perfusion, and many times you can't increase the blood pressure due to other injuries. And so obviously we need to study it more, but I do think it has a role.
All right.
Awesome. Thank you.